So a small last talk by Damien, because he will more of this whole.
So the last talk will be about the kind of system we have developed to help people analyze these images in traumatic brain injury and cardiac arrest. So we use, the aim of this study is basically to automate the pipeline of analysis of both 3D1 information and DTI in patients with acute disorder of consciousness from subarachnoid hemorrhage, intracranial hematoma, traumatic brain injury, and cardiac arrest. So the system takes the diffusion tensor image and the 3D1 and try to, in fact, help the clinician evaluate the probable evolution of the patient as early as possible, because when the patient in the ICU, when he's connected to all these tubes, he is highly dependent on care. And if the patient is going to have a very severe brain impairment, you have to work with family. And maybe if the patient develops a pneumonia, as very often happens, maybe it will not be that necessary to treat him if he's going to have an unfavorable evolution. If, on the contrary, you have a very severe-looking patient, but the brain is intact, you definitely should go on and do whatever it takes to reanimate him. So the aim of this approach is to inform the clinician as early as possible on the probable evolution, neurological evolution of the subject. So, with the fund from the French government, European community, we have developed what's called the ComaWeb system. How it works is that the centers perform the MRI, just upload first clinical information on the system, it generates an anonymization code. You anonymize the image using the anonymization code. It's uploaded through a very secure system to databases in Université Pierre et Marie Curie in Paris, and then the system automatically analyzes the images. There is a final validation, and then we send you back a report, processed images, normalized as to the controls, and some kind of video of the lesion of the brain that I will show you. So the analysis performed on structural images is through the free surfer system developed in Boston. So basically we segment the cortex, white matter, basal ganglia in region of interest, and this will give you the volume of each structure as compared to the controls studied both in your center and in other places. The DTI is segmented on the 20 regions of interest I showed you previously. So, how many centers are currently participating? We have more than 22 centers in Europe, 14 in France. These are all the centers. We recently opened Nice, Saint-Pierre de la Réunion in the Indian Ocean, Papeete in French Polynesia. We also have one center in Belgium, Liège, 10 centers in Italy, one in Spain, in Barcelona, one in Australia. And we are actively collaborating with people from Boston. I will show you part of the thing they are doing. And with also a team at Johns Hopkins. So that's really a 4-continent study currently. We have, at the present time, enrolled nearly 1,200 subjects. Big third of them are traumatic brain injury. We also have subarachnoid hemorrhage, intracranial hematoma, and cardiac arrest. That's the bulk of the patients we are currently studying. Centers are mostly located in France: Salpêtrière, Rouen, Clermont-Ferrand, Liège, La Timone, Monza in Italy, and the other centers. The aim of this system is to give you within 24 hours. So when you upload your examination, within 24 hours you will receive first a quality check. I will show you why it's very important. Evaluation of the lesions, and if you want prognostic information. So you do whatever you want with this prognostic information. The attitudes toward decision made on MRI and decision with withdrawal of care highly variable depending on culture. The people in Belgium use them, let's say, hugely, much more than what we do in France. People in Italy will never use them. So the aim of the study is first to inform the clinician and to inform the family. The decision after, with what you do with that, are yours to make. We have absolutely no interest in that. It does not change the way you take care of the patient, but it helps you give you more informed consent, information to both the clinician and the family of the subjects. So the first step is quality check, because even very small variation in the acquisition parameter will hugely change the values that you get in diffusion tensor. That's a major weakness of DTI, is that, as Catherine showed you with motion, but it's also true with echo time, it's highly sensitive to variation in the sequence and poor quality of the sequence. So automatically it generates a quality check report, so you will get this line showing you motion according to slice number and direction. When the direction doesn't reach the quality threshold, it automatically removes from the analysis. So it tells you that here that one direction had artifact, whether it be motion artifact or other, so it's automatically suppressed from the analysis, and you get this kind of other quality insurance check. So if the DTI sequence passes the quality check, then it's analyzed and prognostic information is generated. But if it does not pass the quality check, it's just discarded. We don't want garbage in, garbage out. The data must reach the sufficient quality threshold determined by the system. You get also free surfer analysis, so you get the volume of all brain region as compared to controls and the variation. So you can, in fact, use this information for your studies. That's available. And then you get these FA maps using DTI. So the patient you have on the left was the guy who had a cardiac arrest, a very severe one. 1 week post-cardiac arrest, he was still comatose. He had all the clinical factors of poor prognosis, hepatic encephalopathy, seizure, lack of corneal response. But in fact, his daughter was an intensivist, and she told us, okay, before we stop everything, I want to know it's really over. And as you can see, he has in fact very few lesions. So they say, okay, he has all the poor clinical prognostic factors, but his MRI is near normal. So they decided to go on. In fact, this guy made a perfect recovery. On the, what is the standard of care in nearly all countries, this guy, they would not have continued intensive care. So it's not only to say bad news to families, but we are also, in fact, recovering patients who otherwise would have been not reanimated. You get these maps plotting the FA value as compared to patients with unfavorable outcome, favorable outcome, and controls. You get the distribution of the FA value in your patient as compared to patients with unfavorable evolution and favorable evolution and unfavorable evolution, then the system plots as best as it can your patient as compared to controls, patients with favorable outcome and patients with unfavorable outcome. So the two huge groups of patients are patients with cardiac arrest and patients with TBI. Patients with cardiac arrest, we have a highly reliable system. Why? Because it's a diffuse disorder, it's symmetrical, you only have one mechanism of injury, low flow, no flow, and these patients are highly homogeneous, and the main factor that we have, prognostic factor, will be the duration of anoxoischemia. TBI, it's much, much more difficult. That's why the system is reliable only for about 2/3 of the patients. Why? You have multiple injury mechanisms, primary, secondary, axonal diffuse axonal injury, concussion. And the lesions are often asymmetrical. So determining asymmetry on image is something extraordinarily difficult, and we don't have a perfect solution at the present time. So cardiac arrest, as you can see, FA in patients with good outcome versus patients in poor outcome. And if you just take the FA of the whole white matter, you can see that CPC1, 2, it's a cardiologist evaluation of favorable outcome, no or minor impairment. 3-5 is major impairment on the test, and you can see that you have a near clear cut between the FA in patient with favorable outcome versus unfavorable outcome. And that's the various prognostic factors that you have at the present time. So it's a ROC curve. This is the current clinical score. And as you can see, its ROC is not that great, meaning that you have still huge uncertainty if you take what is currently the standard of care for these patients. If you quantify the flare, you get even better information. And if you quantify a composite of the FA on the white and gray matter, this is the ROC curve. You are nearly at 100%. So it's a very simple mechanism of injury, and with that, DTI is really highly reliable. Diffusion-weighted imaging was already very good. When you add the DTI information, you are even better. 2 patients, unresponsive, and you will see how huge the differences are. This one had a favorable outcome, this one had an unfavorable outcome. This is the quantification of the destruction of white matter with DTI. You can see that this one has destruction of the whole white matter. This one has some lesions in the watershed territories, but all the deep white matter is normal. That's the difference as compared to control. The bluest is minus 50%. The light blue are around a few percentage. So this guy had a few percentage point of white matter loss in the watershed territory, but that's pretty old. This one has a huge destruction of the whole white matter. And when you plot them as compared to patients with favorable and unfavorable outcome, you can see that this one falls in the favorable outcome group, and this one falls well within the patient with unfavorable outcome. And you really have nearly a clear-cut separation between patients with favorable and unfavorable outcome. Why do we still have patients with unfavorable outcome and good white matter? May I remind you that these patients had cardiac arrest, so they don't have a very well-functioning heart, so they may die of other causes of death. TBI, as I showed you, is much more difficult. We still have huge differences, a very large gray zone, and in this area, we really can't say what's going to happen to the patients. We have less problem of patients dying from other causes. In TBI, usually if you control the intracranial pressure, the patient are going to make it. So this is really uncertainty within the system. How can we progress in reducing this gray zone? Maybe separate axial versus hemispheric injury. These are clearly two different mechanisms. Hemispheric injury are rather concussion, axial injury are deceleration, so that's also two rather different diseases. We are mixing them, maybe we can find a way of separating that. Try to introduce a way of determining the symmetry of the lesions. We still have no simple way of doing that. That's a problem. Analyze tracks rather than MRI. I will show you a small study we did with the people from Martino Center in Boston. And increase power, include more patients. That's going to be part of the solution, but probably not everything. This is a patient who recovered from TBI versus a patient who did not recover. So that's the FA maps. The white contour line are the region the system recognized. As you can see, this one has some lesion here, but strictly unilateral. This one has bilateral lesion. So the major difference between these two patients is that one has just lesion in one part, half of the cerebral peduncle. The patient on this side has a bilateral involvement. This one maybe, this one stayed in vegetative state. Other solution is the tracula system. So that's what's developed in Martino's. The idea is that you do both tracking and quantification. So the system recognizes on the cortex and nuclei the functional region, then performs tracking, and then quantifies the FA, L1, LT along the track. So you get really functional information in addition to your structural information. So that's very preliminary. They are still working on this approach. So the whole purpose is to reduce this uncertainty. That's why we are using this system. Take this patient, 35 years old, 7-day post-cardiac arrest, is in a coma. So the standard of care in most places in the US, in the UK, in most intensive care units in France would be to just, okay, he doesn't wake up at day 7, all the signs are negative, we stop. As you can see, he has some lesions. But otherwise, so if there is no blue, it means that there are no lesions. An early normal break. And as you can see, he falls well within the patient with favorable outcome. So of course they went on and this patient woke up a few days later. 41 years old, TBI, increase intracranial pressure during 30 days. ICP is so huge that you have transudation along the tracks of the ventricular derivation. But look at this. His FA is completely normal. So this guy was able to completely survive with this hugely increased intracranial pressure for 1 month. Most patients will not have made it, but he made it. And you can determine that by quantifying the structure of the white matter. So, if you want to participate, it's complete. I mean, this was developed with a grant of the French government, and the point was you have to make this system available to everybody who has it. So it's available completely free of any charge on everything. The only thing you have to do first is upload controls. Because as I showed you, we cannot do anything if you don't have the normal value of the MRI. So you have to first scan a few controls, contact Professor Pulassé with the investigator, and then you can also have a demo version of the database. you will log in and you will be able to just test the system if you want to. Again, if you want to participate, you are more than welcome. The system is provided really as a service to the community. That's how this study was built. If you have an idea and you want to access this database of patients, it's also accessible for research study. We are more than willing to share this data with anybody who wants to work on these kind of patients. Thanks for your attention.
Quite impressive. I hope many of you will come back to Damien to share and work with him.